Okay, so in this lecture, we'll be talking about joints, especially about joint classifications and also some other features of joints. Okay, so when we say joints, it's not just in the limbs, it is actually to do with the whole body, right? So even though bone, cartilage, skeletal tissues are more towards the limbs module, actually this is, I think, should be included in your foundation module, right? So that is why I have uploaded all the joints and joints, cartilage, and also this lecture we will upload into foundation module, okay? Right, so considering the objectives of this lecture, basically you need to be able to classify joints, right? Then describe the structure of a synovial joint. Then describe the factors that affect the stability of joints. And describe the different types of synovial joints and how they move. Now, when we classify joints, all the joints are classified, and then synovial joints are again classified separately, right? Because that is the most common joint in the whole body, right? Because of that only, we have 2 or 3 objectives with regard to those things. Okay, so also when we consider stability and movement and all those things, synovial joints are the ones that have all of those features, right? So the other joints are a little bit less common and they are not that complex, okay? Right, so when you take a joint, basically, if you try to define joints, we say that a joint is a location at which 2 or more skeletal elements make contact, right? So pay attention to the fact that we have said skeletal elements, not bones, okay? So a joint is a location at which 2 or more skeletal elements make contact. When you say that, all of the joints in the body are defined in that particular sentence, right? So all of them are included in this definition, okay? Right, so then joints are sites of movement and flexibility and also of growth. Okay, so if there were no joints in the body between each of the bones, we will just have something like those stick figures that you used to draw when you were a kid, right? So you have a head and a whole spinal column, legs and hands like this. Okay, so if you didn't have joints, you won't be able to move. The flexibility of your body will be highly restricted, right? That is the reason when people have problems with their joint, they become stiff, right? So if there's pain or any disease of your knee joints, then you can't bend your knee or elbow joint or fingers even, you can't bend them properly, bend and straighten them properly, right? So then these people find it difficult to walk, do their day-to-day work, right? So their whole limb becomes stiff, right? Flexibility is reduced, okay? And also, joints are the site at which you see growth. We studied ossification and you saw that the ossification occurs closer to the joints, right? You saw that the cartilage plates or the epiphyseal plates were found close to joints, right? So joints are sites where you can also see growth. Right, so moving on to the classification of joints, when you take all the joints in the body, we can classify them. Now again, I'm telling you each and every classification. If you read different books, you will find different terms, different names, different classifications, okay? But this is the simplest, easiest, and most practical one. So it's best for you to remember this one, right? So for any questions that may be asked, if you answer accordingly, you will get full marks, okay? Right, so then what are these types of joints that you see? It is fibrous joints, cartilaginous joints, and synovial joints, okay? And then cartilaginous joints are divided into two more types, primary and secondary. Okay, so we have fibrous joints, primary cartilaginous joints, secondary cartilaginous joints, and synovial joints. Okay, so initially we'll talk about fibrous joints first. Here you have two bony surfaces, right? Two bony surfaces, and it is separated. The gap between the two bony surfaces are filled by fibrous tissue, right? So when you say fibrous tissue, it's basically something like a dense, regular connective tissue, right? So you have lots of collagen fibers, lots of bundles of collagen fibers, and that particular membrane fills the gap between the two bony surfaces, right? Or it is like the cement that you use to bring two bricks together, like that. It is the fibrous tissue that brings the two bony surfaces together. Okay, so when that is done, we say that the movement between these joints are negligible, right? So we can't really consider it. Now, initially, the moment we say joint, we think there's always movement there, right? But actually, in some of the joints, their movement is not there. At some point, there may have been movement, but in an adult human, there is hardly any movement. That's why it says negligible. There may be slight movements, right? But it is, we cannot really consider it as a movement. Okay, right. So where do we find these types of joints? We find them in the sutures of the skull, okay, in the distal tibiofibular joint of your leg, right? Then also in a special type of joint called a gomphosis, right? Gomphosis, which is the joint between a tooth and the socket, right? So you know that in your mandible and in your maxilla, you get the teeth embedded in the bone, right? So between that tooth and the, we call them alveolar bone, right? The bone which has the teeth in it is called alveolar bone. And that is, between those two, you get the special type of fibrous joint called a gomphosis. Okay, so here you find a joint between the skull bones, right? We can also call them sutural joints. Okay, sutural joints, and you see them in the skull. So if you take a human skull and look at it, you can see these wiggly lines. Okay, so these are actually the margins of the different bones. So I'm sure you know the bones of the skull, at least if you've done it in Sinhala or Tamil, you know those terms. So basically, this is the frontal bone, this is the parietal bone, right? So between those two, you get this sutural joint. Okay, so that particular joint, this one is called the coronal suture. So that is it joins two plates of bone, right? So the skull, the vault of the skull, this part is called the vault, right? Vault of the skull is made out of these thin plates of bone, where you have compact bone on the surface. In the middle, you have spongy bone, then again compact bone, right? We discussed this when we did ossification. So these thin plates of bone are close together, brought close together or joined by fibrous joints, right? And also these are called sutural joints because these lines, but that is only in the skull, right? In the skull, they are called sutural joints. So this joint, this is all fibrous tissue, okay? And those are the, what we call the suture. So you can see the suture going from the top plate of the bone to the bottom plate of the bone. Okay, so what happens actually is that as the person gets older, just like your cartilaginous epiphysis fuses, these also fuse, right? This is of course after adulthood. It's calcification of the fibrous tissue, right? So that ossification occurs starting from this level and slowly going upwards like this, okay, until it reaches this plate. right? So if it is a very old person's skull, from the inside, if you look, the sutures may not even be there, right? And then when you look from above, you might be able to see. And also in a younger person, the gap between the two bones may be a little bit more than in a really old person, right? So actually, in forensic medicine, they use this to gauge the age of the skull, right? So as you know, there can be human skeletal remains. If human skeletal remains are found anywhere other than in a graveyard, generally they try to figure out the age of that particular human bone, right? So in forensic sciences, they use this ossification of the sutures to gauge or find out the age of the skull, right? Okay, so then also you might see this name somewhere if you look at other books, synostosis, right? That is a special name given for sutural joints, okay? Right. Okay, and then you might also see this sort of joint in the distal talofibular joint, as I said. So between the fibula and the tibia, you get the, tibiofibular joint, sorry, not talofibular, right? So this joint here will have the ligament here and a sort of a capsule. However, this is a sutural joint, but it does not ossify, okay? And in books, you will find this term to describe this specific joint, syndesmosis. Okay, syndesmosis is a fibrous joint that you find at the distal tibiofibular joint. Distal tibiofibular joint. Okay, and then gomphosis, as I said, it can also be called a peg and socket joint because there's a socket. We call it the tooth socket or the cave-like thing in the alveolar bone for the tooth to fit in. That is the socket, and the root of the tooth is the peg. Okay, so this part, this is the socket, and this is the peg, right? So you have a socket like this, and the peg fits in. Peg and socket or gomphosis. Gomphosis actually is the histological or structural type. Peg and socket means just looking at it according to the shape of it, you give that name. Okay, and between now, so you have the teeth, you have the dentine and the enamel outside, right? And between those two, here the tooth surface and the alveolar bone surface, you have something, it fixes the bone really well, and that is called the periodontal ligament. Okay, so the periodontal ligament fixes the alveolar bone to the root of the tooth, right? And the periodontal ligament is made out of dense connective tissue. Okay, so it is the like the cement that holds on to the bone and the socket. Okay, so the tooth, if you want to pull out a tooth, it's quite difficult, right? So to go to a dentist, get anesthesia, and then pull it out using a instrument, right? So it's not easy. So you have to break this joint in order to pull out the tooth. Okay, so that is why it's difficult, because you have a type of fibrous joint which we call a gomphosis attaching the tooth to the alveolar bone. Okay, then moving on to the second type, a primary cartilaginous joints. So primary cartilaginous joints, again, other books might give you different names called synchondrosis. Chondro means anything to do with cartilage, right? So syn means a connection. Synchondrosis is another name given to the primary cartilaginous joint. Okay, so where do we see this? Especially where there is bone and hyaline cartilage meeting, right? So that's why we say skeletal elements, because there is no two bones involved here. You have bone and hyaline cartilage, right? So this sort of joint is completely mobile. There is no movement here, right? So there is a debate whether it can actually be even called a joint, but anyway, these are two different types of tissues meeting, okay? So it is a joint, okay? So where do we see these primary cartilaginous joints? We see it in ossifying hyaline cartilage in the epiphysis, right? So the epiphyseal plate, the connection between the epiphyseal plate and the diaphysis and the epiphysis is the, on either side, you get a primary cartilaginous joint, right? So you have your bone like this. Okay, you have a cartilage plate like this. Okay, so here this is bone and this is cartilage. So between these two, there's a primary cartilaginous joint here and another one here. I mean, all along, right? So between these two, there is a primary cartilaginous joint. Between these two, another primary cartilaginous joint. Okay, so you get primary cartilaginous joints between the bone and the epiphyseal cartilage. Then you get the junction between the ribs and the costal cartilages. So basically what happens is the costal cartilages are made out of hyaline cartilage, right? Thin strips of hyaline cartilage initially during growth forms the ribs. And then from the posterior aspect near the vertebral column, these ribs start to ossify, right? So they continue to ossify, but they don't come to the tip of the cartilage point. They leave a gap. Okay, so anteriorly they leave a gap according to the length of the rib. Some ribs will have a smaller costal cartilage at the end. Other ribs will have a longer one, right? So you know about true ribs and false ribs from A levels, I believe. So some of these will have long costal cartilages, others will have short ones, right? So this joint between the costal cartilage and the end of the rib is a primary cartilaginous joint, right? And it is completely immobile. Okay, do you understand this? Okay, so everyone all right?
Madam, can you explain once again that point?
Okay, right, sure, right? So basically what happens is, now think, okay, so that is the vertebral column. And from that you get a point like this, that is the rib, okay? So it's fixed to the vertebral column. So that rib is made out of cartilage during development, okay? And then from the posterior end, the ossification of this rib starts and it goes on ossifying, okay? So this hyaline cartilage is now turning into bone. So it will come up to a certain point in the anterior chest, okay, and stop, okay? So ossification stops here and all of this is now bone. All of this is now bone and this tiny part is cartilage, okay? So this part is cartilage and this part now is bone, okay? So this joining between, this cartilage and this bone, here you get a primary cartilaginous joint. Okay, is that all right? Did you understand?
Okay, madam, thank you. Yes.
Yeah, you're welcome. Right.
Madam?
Yeah.
Madam, type 1, can you describe small sum?
Type 1?
Yeah.
Insets, type 1?
Yes, madam. Ossifying hyaline cartilage in the epiphysis.
All right, okay, right. So, yeah, I'll just show you the picture. Sorry. Okay, so here can you see the epiphyseal line? So here you have, now here also again, where you get the articular cartilage and the bone also, you get a primary cartilaginous joint, right? So here you have the bone like this, right? And then initially this is also again made out of hyaline cartilage and you get ossification. So ossification will start in the shaft and come up to some point there. So all that will be bone. Okay, and the secondary ossification center will start in the epiphysis here, and again this is bone. Okay, and this part is cartilage, and then you get a rim of hyaline cartilage on top also, like we did in ossification, if you remember, right? So bone is here, cartilage is in the middle. So that is cartilage there, that is cartilage here, and this is bone. And this is bone, right? So you have a place where bone and cartilage meet. So in this area, okay, across like this, you get the primary cartilaginous joint. Okay, is that clear?
Yes, madam. Thank you.
Right. Okay. So this is what you can call the epiphyseal plate. Okay. So here also actually there's a primary cartilaginous joint between the articular cartilage and the bone of the hair, the epiphysis of a long bone, right? Or any bone which has articular cartilage lining it can also be called a primary cartilaginous joint, right? And then here, okay. So this is where the rib ends and where the costal cartilage starts. This point, right? This point is a primary cartilaginous joint, not the other ones, right? This one. Okay. Okay, then moving on to the secondary cartilaginous joints, or what we call a symphysis. Okay, a symphysis. Now, in a symphysis, in a secondary cartilaginous joint, you will have limited amount of movement, right? Limited amount of movement is possible. Okay, and then the bony surfaces of this joint are covered by hyaline cartilage, right? So the bony surfaces involved are lined by hyaline cartilage, and then the two hyaline cartilage surfaces are joined together by a disc of fibrocartilage, right? So you have fibrocartilage and hyaline cartilage in this particular joint. Okay, and there may also be a cavity in between or inside the fibrocartilage, right? So in a sutural joint or in the primary cartilaginous joint, we did not see any cavities. There was no space. Okay, so here, of course, in the secondary cartilaginous joint, there may be a small space, and this space may be filled with a tissue fluid, right? So if you think of the two bony ends like this, right, lined by hyaline cartilage, and a fibrous disc is in the middle. Okay, and in that fibrous disc, you may find a small cavity, right? So that is the fibrous disc. Okay, and this is the hyaline cartilage. Okay, and that would be bone, right? So this whole thing is called a secondary cartilaginous joint. So if you really look at this, you can see that little by little, the complexity of the joint is increasing, right? So it's increasing. Initially, you had only two types of tissue, but now there's a third type of tissue. Okay, right? So within this secondary cartilaginous joints, again, there is cartilage and there is bone. However, there are two bony ends and cartilage in the middle. Okay, is that clear?
Yes, madam.
Okay. 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 So within the fibrocartilage, you may get a cavity filled with tissue fluid. Okay. Right. So then, where do we see these symphysial joints? Generally, all of the symphysial joints in the human body are found in the midline. Okay. So what are these joints? We see the manubriosternal joint between the manubrium and the body of the sternum. Okay. And then the syphisternal joint between the body of the sternum and the xiphoid process. Okay. And then we see it in the intervertebral joints, right? So intervertebral joint, if you look at a cartilage disc, it is the vertebrae on either side are lined by hyaline cartilage, and then the cartilage disc is made out of fibrocartilage. There's, of course, a gelatinous substance in the middle, similar to a cavity, but it is filled with gelatinous substance, right? So that is the structure of a intervertebral disc, right? So intervertebral disc is actually joining the two vertebrae on either side, okay? And then you see the symphysis pubis, which is a joint between the two pelvic bones, right? And then the sacrococcygeal joint, which is a joint between the sacrum and the coccyx, right? So in humans, the coccyx is tiny, right? At the end of like a small triangular piece of bone at the end of the sacrum. However, there is a small symphysial joint between those two bones. Okay, so here you can see the vertebral discs or intervertebral discs, and as you know, they are made out of two types of tissue, and we call them the nucleus pulposus and the annulus fibrosus. Okay, so the annulus fibrosus, this is the part which is made out of dense connective tissue and fibrous cartilage, right? So the nucleus pulposus is actually gelatinous-like substance, right? Gelatinous substance, which helps to absorb the shock, right? So this fibrocartilage also, because it's not as hard as bone, it can compress during movement and allow absorption of shock, right? So the spinal, the vertebral column actually gets all the shocks of movement, right? Walking, then whatever heavy weight lifting, whatever you do with your arms, all that, the forces are all directed through the girdles, like the pectoral girdle and the pelvic girdle, towards the vertebral column, right? So this shock absorbing property of the vertebral column is given by these intervertebral discs, right? So this joint, then the surfaces of the intervertebral disc is lined, the vertebrae are lined by hyaline cartilage. So this surface will be lined by hyaline cartilage, okay? Cartilage, right? So two layers of hyaline cartilage on either side, and the intervertebral disc in the middle gives rise to a symphysial joint or a secondary cartilaginous joint. Okay, right? Are you okay with that?
Yes, madam.
Yeah, so then we will move on to the joints which are really important, especially in movement of the limbs, what we call the synovial joints. Okay, again, another name, diarthrosis, may be given in other books. Okay, so synovial joints are the most common joints in the body, and basically these are the joints that are specifically designed for movements, right? So all these things that we talked about, like flexibility, movement, growth, all of these occurs around the synovial joints, right? So it's called a diarthrosis as well, and it is highly mobile. Okay, so 99% of the joints that you find in the limbs are synovial. Okay, right. So what are the features of these synovial joints? The bony ends of the synovial joints are covered by specialized hyaline cartilage. We looked at the structure of the articular cartilage, right, during the cartilage lecture. So you saw that they are the remaining part of the ossification process, and they are specialized and they're quite thick, right? However, they do not have a perichondrium covering it. Okay, since they're hyaline cartilage, they are wear-proof. Okay, and as long as the cartilage is healthy, they are wear-proof. Then compressible, that means you can compress it, change the shape, and they will come back to normal a little bit, right? Not a lot, but it's compressible, more compressible than bone. Okay, and low in friction. Okay, so if two bony ends were moving against each other, there would be lots of friction because the bone is hard. right? However, articular cartilage is softer and they are wear-proof and compressible. Because of that, they become low in friction, right? So friction between the two ends of a bone can actually give rise to a lot of pain and also difficulty in movement, right? So this ability of the articulate joint to have low friction is important in movements. Okay, right. And then the two bony ends are covered by a capsule. Right? So actually, even in the symphysis pubis, actually, in the where the two pelvic bones meet, you kind of have something similar to a capsule, but it is not a real capsule, right? So a real joint capsule is seen, sorry, in a synovial joint. Okay, right? And also a really specific joint cavity. Okay, joint cavity, which gives the space for movement. All right. So if two bone ends are very tightly fixed together, then it can't move that much. Okay. So because of that, there is a tiny space left between the two joints so that more movement can occur at those joints. Right. And then you have a very special membrane called a synovial membrane. Okay, synovial membrane, which secretes synovial fluid. Okay, secretes a fluid. It is like a lubricant, right? So even if you have seen any kind of machine, right, even a sewing machine, you must be having, I don't know whether you still have sewing machines at home, but if you do, you know that you have to put oil into the sewing machine, right? And of course, even vehicles, you have to put oil into it, and bicycle chains, things like that. And any kind of machine, you have to put oil into it, right? Because the moving parts, when they move against each other, friction is caused. And to reduce that friction, you put oil, right? So like that oil, in these joints, you get synovial fluid. Thin film of fluid, which is secreted by the synovial membrane, and it causes lubrication and reduces the friction. Okay. Right, and then also surrounding the joint, you get ligaments, right? Ligaments that strengthen the joint. Right, so the surrounding the capsule, actually outside of the capsule, sometimes you can get different ligaments, but ligaments that strengthen the joint. Okay, and then also a special feature called a bursae or bursa. Bursae is plural, bursa is singular. Okay, and that is synovial fluid filled sacs. They are like synovial membrane lined sacs made out of connective tissues that may be between tendons and bones, and they give a cushioning effect, right? And also again reduce the friction. Okay, so bursae are like, now if somebody has, if someone's bedridden, right? If you've had injury or a stroke or something and they're bedridden, the bony points in their bodies, sometimes when there's friction between those points and the bed sheets or whatever surface they are lying on, they can get injured, right? You can get, skin can get bruised. Right, so in those days you put something called, you can actually in hospitals we used to do that, just fill out a glove with water and place it between that bony point and the surface, right? So that friction is reduced. So similarly, it is like a cushion. I mean, similar to a cushion, right? So if you are having a backache or something, you will put a cushion underneath it to reduce the shock, right? And also to reduce the friction between the surfaces. Okay, so bursae are like that. You get synovial fluid filled sacs, which are between, because if the tendon and the bone sort of rub together, then again there's friction there and there can be pain and difficulty in movement, right? So you have this bursa to reduce that. Okay, right? So if you draw a very extremely diagrammatic representation of a synovial joint. You have the bones on either side, right? Sorry, bones lined by, this is the articular cartilage, lined by articular cartilage, right? So the two bony ends, this is also bone, lined by articular cartilage, given in blue color, right? And the synovial cavity filled with fluid. That is the most important part of this, right? Synovial cavity filled with fluid. So there is synovial fluid in this area. And you can see the synovial membrane is marked in red. It lines the bone surface, right? And then reflects onto the inner surface of the capsule. But you can see it does not extend to the articular cartilage, right? So the articular cartilage, because it can't really, because articular cartilage will initially during development, synovial membrane is there around the articular cartilage also. That's what they say, right? But when the two bony ends rub together, the synovial membrane gets sort of dissolved like, right? So in adult synovial joint, the synovial membrane will end at the points where you see the articular cartilage, right? So the inside of the capsule and the bone within the capsule is lined by synovial membrane, right? So it is like the capsule is the one that is containing the joint or keeping the two bony ends close together, right? So if the capsule is damaged, then the joint becomes very lax, right? Or the two bony ends cannot stay together, okay? Right, so here is a radiograph x-ray of a knee joint, okay? So we have seen, these are adult one because you can't see any of the epiphyseal plates. So this is an adult one and there is a joint space, right? So this is a space between it, right? So the bone is in white and soft tissues in black. Right? So cartilages actually do not show up in an x-ray. So the space, the joint space, is because of the small synovial cavity and the articular cartilages. The synovial cavity and the articular cartilages give rise to the joint space, right? So the space seen in any joint, you realize that there is a joint there because you see this space. All right, and the space has to be there, otherwise movement becomes difficult. If the space is reduced or any change is there, then you know that something abnormal has happened, right? So in x-rays, you can't see cartilages that well, okay? You might be able to, I mean, usually not there unless it's calcified, right? So it is a calcified tissue that you can see clearly in a radiograph. Of course, you see what are called soft tissue shadows. Now here you can see the muscle shadow of the leg, right? Light shadows like that. Okay, those are the shadows of the muscles, right? However, the bones are very clearly visible. So that is the femur and the tibia. Okay, is that all right?
Yes, madam.
Okay, so understand the concept of why you have this space between the two bones in a synovial joint, right? Even the sutures are visible, right? Sutural joints, sutures, because that area, the bone is thicker, okay? So if you see a skull x-ray, you can very clearly see the sutures on it, right? And then we will talk a little bit more detailed about a synovial joint because all the joints that you're going to learn in the limbs are synovial, right? So, so you have all these different parts related to a joint. The ligaments, right? Ligaments are connective tissue elements, a dense regular connective tissue, which joins one bone to the other, right? So these ligaments will strengthen the capsule, okay? And then you have tendons, which are the connective tissue elements of a muscle, right? So muscle ends in a tendon, again, dense regular connective tissue, like a thick cord, okay? So if you want to feel a tendon, you can feel your Achilles tendon at your calf, right? End of your calf, near your ankle, you can feel your Achilles tendon. It's very hard, sort of tight, thick tendon. Okay, so tendons will help to attach the muscles close to bones, right? So tendons will generally cross a joint and attach to somewhere close to the joint, right? Just distal or just proximal to each of the joints. Okay, and then of course we said bursae. Okay, bursae. Right, so what are these bursae? So I said they are sacs of synovial membrane filled with synovial fluid and also surrounded by a layer of connective tissue. Okay, so during dissections, it's really difficult to see the bursae, but in x-rays and all you can see, and also you can see the small spaces between left by the bursae, right? Because when they collapse, you can't really see them easily. Okay, so you find these around joints and they give cushioning effect to the areas where ligaments or tendons come close contact to bones. Okay, so you have lots of named bursae when you're learning about the different joints of the limbs. You will come across these names, right? So especially around the shoulder joint, you have lots of bursae, right? One of the commonest one is the subacromial bursa. Okay, and then you have the prepatellar bursae and the infrapatellar bursae and lots of small bursae all around the knee joint. Okay, knee joint. Okay, and also sometimes these bursae can either be connected to the joint cavity as well, right? Like the subscapularis bursa and the infraspinatus bursa of the shoulder, right? So you can go and read about the bursae, and when you're studying about the shoulder joint, you will see these bursae. Okay, right. Okay, so here you see the subacromial bursa. Okay, so this is between, this is the acromioclavicular joint here, and you have the supraspinatus tendon here. Okay, that is the humeral head, right? So that is the greater tuberosity. So there are bones and muscles, tendons, lots of things happening here, and there can be a lot of friction. And abduction of the shoulder, that is moving the humerus like this. Abduction of the shoulder is one of the movements that is done constantly. Okay, so there's a lot of movement in that area, and there's only a little bit of space, so you can get a lot of friction there. So you have the subacromial bursa here. Okay, so you can sometimes get inflammation of these bursae, right? When there's lots of movement, if you move your arm a lot during a sports event or something like that, you can get inflammation of these bursae as well, right? So when there's inflammation, that means inflammation means you get a reaction, right? So there's injury to that area or there's excess movement. So tissues have been stretched and there's injury. So the body is actually telling you to rest, right? So inflammation is a reaction to any kind of trauma or damage. Okay, so when you have inflammation, you have swelling and pain, and the body is telling you to rest, right? Stop moving your shoulder and rest. Okay, right? So as I said, bursae around the knee, suprapatellar, all these you can learn when you're learning about the knee joint, right? So here you can see sometimes now here the patella is there and the skin is there, right? So this is actually between the patella and the skin, because the patellar bone can actually cause friction on the skin. Okay, so because of that you have a bursa there. And then this is the quadriceps tendon. Between the tendon and the femur, you have another bursae, right? And then this area is actually rough, the tibial tuberosity, and between that and the patellar ligament. And again, between the ligament and the skin also you can have a bursa, because if you are kneeling on the ground or anything of that sort, you can get a slight, you can get friction. Okay, give me a little. Right, so bursa can be there between the skin and the ligament or a bone as well, right? So that you reduce the friction when, like if you're kneeling on the ground and your bone hits the ground, there can be a lot of friction and the skin can get damaged, right? Because of that, you have is per se. Okay. Right. So then we'll go on to classification of synovial joints. Okay. So this happens. This is now because the synovial joints are so common, we classify them again. Okay. And now initial classification was according to the structural elements or the histological structure of the joints, right? So we are talking about the tissues that make up the joints, right? Tissue layers, different types, and that was the basis of that classification. But now we are talking about classification of the particular synovial joints, and we are doing that according to the shape of the articular surface, right? Shape of the articular surface. All right, so if you look at different joints, they have different shapes. Okay, so the simplest possible things are the plane joints, or what we call the gliding joints, right? And then we come to the hinge joints. Now, gingivimus, right? That's a nice word, no? Yeah, so that these are just words that you come across when you read your textbooks. Okay, so the older sort of terms, right? And then pivot joint, okay, may be called trochoid or rotatory, okay, pivot joint. Then a saddle joint, ellipsoid joint, and ball and socket joint, right? So all these are according to the shape of the articulating surface, okay? Right, so then looking at a hinge joint, okay, hinge joint, it is like a door hinge, right? So you see it all the time when you open or close a door or a window, there's a joint between the closing the door and the wall, right? So that is called a hinge, right? So similar to that, you get a lot of hinge joints in the body, right? So according to the shape of the articular surface, the movements that are possible at these joints will change. Now a door cannot be turned anywhere else other than opening and closing. You can't rotate the door or do any other movement except for that particular movement of opening and closing, right? So like that, if there's a hinge joint, it only allows flexion and extension. Right, so I hope you know flexion and extension, right? You have done the initial things, right? So flexion and extension. Flexion is bringing the two bony ends close together. Extension is bringing them apart from each other, right? So if you take the elbow, bending your elbow is flexion. Straightening your elbow is extension, right? So elbow joint, the proper elbow joint, actually the joint that is there at this point. Okay. So this is the ulna, okay, and that is the humerus. Okay, so that particular joint is a hinge joint. And then of course the interphalangeal joints of your fingers. If you bend and straighten your fingers, that is where you find a hinge joint. Okay, and then the knee joint, it is a complex one, and the ankle joint is also, ankle joint proper is a hinge joint, right? So hinge joints are the commonest type, interphalangeal joints, elbow, knee, and ankle, right? And then you have the pivot joint, right? Pivot joint or rotational joints. These allow rotation, axial rotation, right? So this pivot joint, of course, allows only rotation. There's no other movement possible at this joint. It allows only rotation. Okay, so pivot-like process, turning within a ring or vice versa. Okay, so either the ring can be moving or the pivot can be moving. Okay, so if you think of the atlantoaxial joint at the in your neck, right? So this is the first cervical vertebra, the atlas. Then this is the second cervical vertebra, which is the axis, right? So you can see this peg, which is called the odontoid process, and then there is a ring. This part is bone. This part is a ligament. So there's a ring like this. Okay, so this peg fits into this ring. So there's a ring, and the peg fits into the ring and moves inside that ring. So it rotates. Okay. So here, of course, in the atlantoaxial joint, what happens is it is the axis that moves. Okay. So around this odontoid peg, the axis will move. Okay. In a circular motion, so that your the head will move. Right. Okay. So the process of saying no, right? Moving your head from side to side. Right. And also you can get a ring forming. The ring is there and the peg is moving, that you see in the proximal radioulnar joint, which you will be learning soon. Proximal radioulnar joint, right? So here you see this is the radial head. Okay, this is the ulna. There's a small sort of cavity-like thing here, right? The radial notch, and the head of the radius fits into that notch. And around this, you get what you call the annular ligament, right? A C-shaped ligament which joins the two ends and forms a sling around the radial head. Okay, so like a circle around the radial head, so that the radial head can rotate within this circle, right? So this prevents the radial head from slipping away, but it has the ability to rotate on its own axis, right? So that is what we call axial rotation, right? Rotating on its axis. Okay, right? Did you understand that?
Yes, madam.
Yes, madam.
Okay, right. Right, so then plane or gliding joints, you see them where the two surfaces sort of glide on each other, right? And the range of movement is limited by the ligaments which surround these bony processes, right? So if the ligaments are not there, all these bones will fall apart, right? So like that, they won't be held because of the shape. They are just two flat surfaces sort of moving on each other, right? So the ligaments will keep them in place. So these sort of joints you see in joints between the articular processes of the vertebrae, okay, and carpal bones and tarsal bones, right? So if you look at the surfaces of these bones, and if they are mostly flat, then we call them plane joints, right? So sometimes there can be slight cavity and a slight elevation, right? So there may be debate between whether it's actually a plane joint or not, right? But as long as the surfaces are generally flat, we call them a plane joint. Okay, so there's only sort of gliding movement, adjusting sort of movements. There's no wide range of motions there, just gliding on the two surfaces, right? And complete gliding and loss of articulation is prevented by the ligaments. Okay. Right, so then coming on to a saddle joint, here what happens is the surfaces become convex. One becomes convex, one becomes concave. All right, so like one surface is like this and the other surface is like this. Okay, concave or convex, so articular surfaces of each bone, right? So saddle joint, the typical one is the carpometacarpal joint of the thumb, right? So if you look at books, there may be other ones, but this is the typical joint, a saddle joint, which is seen in the carpometacarpal joint of the thumb, right? Sorry, right? So this is slightly more curved than a gliding joint, and because of that, it can allow more movement, right? So the thumb is actually this particular joint of, the carpometacarpal joint of the thumb is highly mobile and it can move in different planes, right? So it allows flexion and extension, adduction, abduction, and also a combination of these movements, which we call circumduction. Okay. However, there is no axial rotation of the thumb, right? So if you read other books, they may talk about rotation, but actually what they're talking about is the circumduction. Okay. So you cannot rotate the thumb against its axis, right? So the axis, axial rotation cannot be done at the thumb, but all the other movements are possible. Okay. Right. So carpometacarpal joint of the thumb, remember that it's a saddle joint and it allows all these movements. When you study the hand, you will be learning more details about the movements of the thumb. Okay, right? So then ellipsoid joint, where the two articular surfaces are not rounded but ovoid. Okay, ovoid articular surface, and the condyle, or what is going to join there, is also elliptical, right? So the cavity is elliptical, and the other end is also elliptical. So because of this lengthening, you don't have rotation. Again, you can't have rotation because it's a ovoid articulate. The shape is ovoid, right? You can't spin, you can't turn in that, right? But it allows flexion, extension, adduction, abduction, and circumduction. Again, if you take your wrist and you spin your wrist, you will think that it's rotation, but it is not. It is circumduction, because if you carefully look at it, you see that you're flexing, adducting, abducting, extending. Sorry, if you take you flex your wrist, right? Then adduct your wrist, then extend your wrist and abduct your wrist. So that is what you are doing actually, a combination of these movements, right? So there is no axial rotation. It's not possible because of this shape, right? So the typical example for ellipsoid joint is a wrist joint. Okay, right. Okay, then you have the other type, which is called a ball and socket joint. Okay, so ball and socket joint is where you have a globular head and a cup-like cavity, right? So the globular head, or a globe-shaped head, and a cup where it fits in, right? So you have a cup-like surface and a ball-like surface which fits into it, right? So you have a cup and a ball like this, right? So ball and socket joints are the ones that give you the maximum amount of movements, right? So it can move in all the planes, right? So that is why we call it multi-axial. Okay, multiple axes, lots of axes, right? So it can move in many planes. All right, so it allows all the possible movements of abduction, adduction, flexion, extension, and medial and lateral rotation. Okay, so if you think about your hip joint and your shoulder joint, those are the largest ball and socket joints in the body. The largest joint is the hip joint, basically. I think the knee joint is second, right? Anyway, the largest ball and socket joint in your body is the hip joint. Okay, so it has a very deep cavity and a rounded head of the femur fitting in nicely together, right? So that is the most stable, largest joint, ball and socket joint in the body, right? The hip joint. Okay, right? So hip joint, you can move it in all directions. Similarly, the shoulder also, you can move in all directions. Now, the reason is this, because from your shoulder only, you move your arm to wherever you want to place it, right? So if you want to pick something up from a shelf, or if you want to reach out and close a door or a window, you want to draw something, you can move your hand all over the page, all over your range, because of this ability to move, this multi-axial aspect of the shoulder joint, right? So mostly when the joint is close to the body, you see that the range of motion is higher. Okay, so the hip and the shoulder are the two joints which have the most range of movement. Okay, did you understand that?
Yes, madam.
Okay, right. Okay, right. So then we move on. Okay, so when I've been saying this word over and over, range of movement, or ROM as we call it, it's really important, basically, because that is the one that decides how you can move your joints, right? So the range of movement of different joints are obviously different. Okay, so if you are going to measure this, what we do is we measure the angle between the axis of each of the bone, right? So the longitudinal axis or the long axis of the bones, we will move them towards the extreme ends and then measure the angle between them, right? So if you think of the elbow joint, you will extend the elbow as much as possible and then measure the angle between the humerus and the radius and ulna, right? So the surface of the radius and ulna and humerus, what is the angle? Okay, when you fully extend it. So it may be slightly more than 180, okay, slightly more. And then you bend your elbow as much as possible, bring it as close to the, so you bring the forearm as close as possible to the arm, and then you measure the angle between those two surfaces. Then you get the smallest angle, right? So that may be about 30 degrees maybe, okay? And then you say the range of motion in the elbow is 30 to 100 and maybe 82 or something of that sort, okay? Right? So for each specific joint, you have a normal range of motion and we express it in degrees. We use a protractor, okay, a protractor to measure the angle between these joints. Now this becomes really important, especially if somebody is recovering from an injury, right? So if you have an injury, movement of that limb becomes less, right? So this is very important, especially in sports, right? Specific degree is important for them to be able to bend their knees or elbows or whatever accordingly, right? So to check whether your treatment is effective, you will use this, okay? Right, so how do you measure this? By using what we call a goniometer, okay? And yeah, so then you can actually say what is the degree of motion. So depending on which side you're using. So knee flexion is 130 to 150 degrees. So you can measure it from the other side, then it will become larger. And how you flex and extend your knee, right? Okay, so that is what we call a goniometer. So this is basically a protractor. In Sinhala, it's called a konamanaya, right? I'm sorry, I don't know the Tamil term, but looking at this, you know what it is. And these are the two arms of the goniometer, like two rulers. Okay, so you extend one ruler like this and the other one like this, and you measure this angle to see how much it is. And also you can measure this angle also, right? So depending on which angle you measure, you get a certain amount. Okay, so you can say what is the most flexed knee angle, then extended knee angle, like that, right? So you say that this is a football player and they had some injury, and the physiotherapy people, the physiotherapist will give exercises and all sorts of treatments, and initially they will measure the angles and then give the treatment and measure the angles again to see if there's any improvement, right? Okay, so then what are the factors that determine the range of movement of a joint? Right, so we've been talking about this all along, the shape of the bony surfaces. Okay, so the shape of the bony surfaces is the most important determining factor of the range of movement, right? And the ball and the socket joint is the one that has the highest range of motion, right? So the ball and socket joints have the highest range of motion. And also laxity of the capsule and the ligaments which are surrounding it. It is like if the capsule is really tight and very close to the joint and short, right? There is no space in the joint. Then the tight capsule will make it less able to move. So the ability to move will be less, or the range of motion will be less if the capsule is very tight. Okay. But if the capsule is lax, then the movement will be higher, greater, right? And then, of course, intervening soft tissues. So if you have a big bicep, right? If you've done weights and all that, and you have a huge, big bicep, then you cannot flex your elbow that much, right? But if you're very thin and you hardly have any fat, then you can flex your elbow to the maximum, right? So whatever the intervening tissues, either muscle or fat tissues, will again reduce the range of motion in that sense. Okay, so the shape of the bone, surfaces of the bone, the laxity of the capsules and the ligaments surrounding the joint, and the intervening soft tissues are the three factors which determine the range of motion of a joint. Okay, so this is again the ROM of the knee. So it depends again on the position as well. So if you're seated, then the range of motion will differ or change a little bit or as to when you're lying down. Okay, so like that, for different joints, you will have different ranges of motion, and for different people, it will be different, right? So somebody like a gymnast will have a high range of motion in all of the joints. Okay. So it depends on how you trained yourself, how much you moved your joints, and how lax your ligaments and your capsule is. Okay, so if you go on training yourself from a young age, your flexibility will increase, right? So if you don't do it, then the joint flexibility will be reducing a little by little, right? However, normal person will have a certain degree of movement, which is absolutely necessary for their day-to-day functioning, okay? Right, so then going on to something called stability of the joints. Now again, actually, because there is a space there and because there is movement there, the sides of joints are actually places where you can get problems, you can get diseases occurring, as well as you can get traumatic injuries, right? So you can get because there's a gap and because there is a space there, you can get what is called dislocation, that is loss of articulation, right? So the two surfaces of the joints have to be articulated properly in order to work properly, right? So if you get dislocation or the articulation, loss of the articulation, then that is a problem. That is a disease, not a disease, I mean, it's a condition, okay? Right, so during the day-to-day movements, you have to, the joints have to be stabilized so that they don't lose their articulation. If they lose their articulation, they can't work properly, right? So basically what we say is that all of the joints are stable, right? So all these factors are there, different factors in different amounts are there to stabilize the joint. However, there can be problems, okay? So the most mobile joint of the body is said to be the shoulder joint, and also it is the one that is dislocated most, right? So that is because you actually have stability and mobility like on either side of the weighing scale, right? So more stable it is, the less mobile it is. More mobile it is, the less stable it will be, right? Okay, so, and also the shoulder is used a lot. It moves a lot and you use a lot. And also if you fall, you put your hand out and try to prevent your fall. Okay, so that the shoulder gets all sorts of traumatic injuries, and because of that, it becomes the most, I mean, statistically, you see that it is the most dislocated joint in the body. Right? But do not ever say that joints are not stable, because all joints are stable, because no, I mean, I'm sure none of you, maybe one of you or two of you maybe have had a dislocated joint, right? So very rare, you don't really see it that often, right? But when you consider all the dislocated joints in a year or something in a hospital, the commonest would be a shoulder one, right? Okay. Right, so what are the factors that stabilize the joint? Well, basically, you have three factors: bony factors, ligamentous factors, and muscles. Okay, bony factors, ligaments, and muscles. Right. So the shape, bony factors means the shape of the articular surfaces, and also maybe other bony projections and things which are surrounding a particular joint. And then the ligaments are the ones that surround the joint. and the capsule is also included in the ligament. Some books describe the capsule as a capsular ligament, right? And then, of course, muscles and their tendons, which tend to contract and keep the two bony ends close together. Okay, so these are the three factors that stabilize a joint: bony factors, ligamentous factors, and muscular factors. Okay. Right, so from that, we'll take the shoulder as an example. And what are the bony factors, right? The thing about the shoulder is that the humeral head, the head of the humerus, is very large, right? Quite large. It is not a complete sphere. It's about 3/4 of a sphere. However, the glenoid cavity on the side of the scapula is quite shallow, right? So if you look at the glenoid cavity, you will see that it is quite shallow, right? So we'll talk about osteology tomorrow in the practicum. So you can see all the bones and everything. I'm sure you have seen pictures of those. So glenoid cavity is shallow, and because of that, it offers very little stability. Okay, so the bony factors, when you consider the shoulder joint, offer very little stability to the shoulder joint, because the glenoid cavity is shallow, even though the humerus head is quite large. Okay, so that again gives the shoulder a lot of mobility, right? So the stability is very little because the glenoid cavity is shallow, but the humeral head can move quite freely in it because it is shallow again, and the humeral head is large, right? So at the expense of the stability, you get more mobility, right? So how does the shoulder stay stable? It is the other factors, right? So there are ligaments that strengthen the capsule, right? So surrounding the capsule, there are ligaments. Now the shoulder capsule is actually very strong, but it is lax, okay? So lax means there is more space, all right? But the shoulder capsule is really strong because it's made out of a lot of thick, dense collagen fibers and strengthened by ligaments, right? However, the most important factor when it comes to the shoulder is the muscles and the tendons that surround the shoulder and give it stability, okay? So what are these muscles and tendons? It is the rotator cuff muscles, right? So remember the rotator cuff, read about it. We will learn more about it as we go along. These are the small muscles or thick, bulky muscles, which short, thick tendons that surround the shoulder, okay? Rotator cuff muscles. Then also we have biceps and triceps, which are the arm muscles of the arm, and their long tendons, which attach to the surrounding the shoulder joint, also give it stability. Okay, so if you are discussing the stability of the shoulder joint, the most important factor is the rotator cuff muscles and the tendons of the long tendons of the biceps and the triceps. Okay. Right, so if you look at this, you can clearly see the glenoid fossa is extremely shallow, right? Very shallow, and the head of the humerus is quite large. Okay, so the shallow glenoid cavity and the head of the humerus fits into it. Sorry, where did I go? Sorry, fits into it like this. Okay. Okay, so because of that, it has the ability to move within this shallow cavity much more, right? And here, of course, you can see other bony factors. There's a bony arch, right? So the coracoacromial arch, that also prevents the shoulder from dislocating, right? So it doesn't really move upwards like this because of this arch. Okay, so the bony factors actually offer very little stability, but you have the capsule surrounding it like this. Okay, that will give a lot of stability. And then the muscles of the rotator cuff and the long and short head of the biceps, right? So they will be attached like this and preventing the head of the humerus from slipping away from the glenoid fossa. Okay, So we will talk about the joints of the shoulder later as well. So we'll learn more about that. Okay. Right. So that to summarize, you have the fibrous joints. Okay. So I hope you understood about the stability of the joints. Is that clear to you?
Yes, madam.
Okay. Right. Okay. So if I ask you what do you think is the most stable joint in the body? I mean, when it comes to synovial joints.
Hip
Hip
joint.
joint.
Yeah, very good, right? Yeah, good. Hip joint, right? Because hip joint, you see that the cavity is very sort of deep, and even though the head of the femur fits very nicely into the acetabulum, right? So it's very nicely fitting in. So the fit is perfect, like, and also there are lots of ligaments, very strong ligaments, and a lot of muscles as well, right? Though it is a very sort of stable joint, it is also mobile because of its shape again, right? So you understand that the mobility and stability are on either side of the weighing scale, right? Okay. Right, so you have just to summarize what we were talking about. So you have the fibrous joint where the bony ends are joined together by fibrous tissue. Only minute movements are possible. Then you have primary cartilaginous joints where you have bone and cartilage, hyaline cartilage, which are very firmly joined together. There is no movement possible there. Then you have secondary cartilaginous joints where you have the bony ends, which are covered by hyaline cartilage and joined by fibrous tissue. And there may be tiny cavities, but there is limited amount of movement there. Okay, so there has to be a little movement in these joints, in these symphysial joints, right? And then, of course, you get the synovial joints where the bony ends are again lined by hyaline cartilage. And very importantly, there is a cavity that surrounds the joint, a capsule, which is lined by synovial membrane. And that allows the widest range of motion. And that is the joint which is designed for movement. Okay. Right. So these are here some joints here. Can you just tell me what is the joint which you find here?
Fibrous.
Yes, fibrous. Good, right? So it's a fibrous joint because it's the distal tibiofibular joint. Here,
Fibrous
Fibrous
joint.
joint.
yes, fibrous joint, which we will call, another name is a suture. Yeah, right? Suture. Yeah, sutural joint or a suture, skull, a suture. Okay, and this is?
Cartilage.
Yes, cartilaginous. It is secondary cartilage. Yeah, secondary cartilaginous joint, or we can call it, we don't generally call this a symphysis, right? But this is a secondary cartilaginous joint, yes. So here,
Primary cartilage.
Primary cartilage.
Primary cartilage.
yes, good, right? So that is a primary cartilaginous joint. This joint is a synovial one, right? This first one, sorry. This is again the primary cartilaginous because this is a first rib, right? But other ones will be synovial, okay? Other costal cartilages, here there's another costal cartilage here, that would be synovial, okay? So these two are primary cartilaginous, okay? Then here we have some pictures of synovial joints according to the shape. So this one is what shape?
Ellipsoid.
Yes, correct, good, right? This is? Sorry?
Ball and socket joint.
Yes, okay, very good, right? So actually, yeah, because actually when you look at this, it looks like a ball and socket joint, right? So you have this ball and this has a socket here, okay? So that is because of the curvature of it, right? Actually, this is, of course, the elbow joint. So it is actually a hinge joint, but what you say is true because part of that hinge joint is actually a ball and socket, right? But because of the other bony elements, the elbow we consider as a hinge joint, right? This one?
Ball and socket joint.
That's ball and socket. Yes, correct. That's the hip one, right? This is
Plate joint.
Saddle joint.
Saddle.
saddle
Saddle
joint.
joint.
Yes, yes, good, right? So it's a saddle joint. The shape is like this. That is why it's called a saddle, right? Saddle of a, when you ride a horse, you get the saddle. That is a saddle joint. This is,
Pivot joint.
yes, right. Good, right? So that's the pivot joint. Okay. So I think you're okay with all that and you've understood what I've been trying to say. Okay. So this is again a simple lecture. Remember this, you don't need to go on and study this again. I suppose you can read about the bursae and the different joints. Remember the classification, and that's more than enough. Okay. Yeah, so I will try to send some papers to you. Your Avishka has been reminding me several times, but I don't have the papers at home. That's the problem. I'll try to send them today, right? I sent a few to him, I think. Okay, so yeah, so now we will stop, right? If you have any questions, I will take questions in the afternoon when we do the practical, right? Okay, so we'll end this now.
Thank you.